Today I'm going to show you how to perform an interscalene brachial plexus block to obtain analgesia to the proximal arm and shoulder. The goal here is to anesthetize the C5 through C7 nerve roots of the brachial plexus with ultrasound guidance so that you can see the spread. The learning outcomes for an interscalene block are that students will be able to understand the concept and technique. They will also be able to identify the relevant surface anatomy and the nerves that are being targeted, as well as the local anesthetics that are commonly used, and understanding the benefits, potential risks, contraindications, and importance of proper patient assessment. Lastly, students will be able to apply basic pharmacology and dosages for effective and safe anesthesia. Before we begin the block, it is important to make sure that your patient does not have severe COPD, contralateral paresis of the phrenic or recurrent laryngeal nerves, infection at the site of injection, coagulopathy, or local anesthetic allergy, because those are some common absolute contraindications for this block. Be sure to obtain consent from your patient and warn them about temporary phrenic nerve paralysis, recurrent laryngeal nerve blockade, or Horner syndrome. The necessary equipment needed for an interscalene block are the standard ASA monitors, chlorhexidine to prep the skin, midazolam or fentanyl for sedation if there are no contraindications, an ultrasound machine with a linear transducer, lidocaine for local injection, a standard nerve block tray, a 20 milliliter syringe containing the local anesthetic, as well as a 5 centimeter 22 gauge short bevel insulated stimulating needle, sterile gloves, and an optional peripheral nerve stimulator. For this block today, we will not be using a peripheral nerve stimulator. This block is typically performed for shoulder surgeries, total shoulder replacements, and other surgeries that do not involve the medial aspect of the arm or forearm. The goal here is to anesthetize the C5 through C7 nerve roots of the brachial plexus with ultrasound guidance so that you can visualize the spread. Now that we have covered some preoperative basics for this block, we can move on to the procedure. For positioning, it is ideal to have the patient supine or in the lateral decubitus position. For today's demonstration, the patient will be in the supine position with their head turned away from the side of where the block is going to be performed. Before performing the block, it's important to identify the surface landmarks when locating the interscalene space. When placing my ultrasound, I will start with the probe over the supraclavicular region posterior to the clavicle, aiming straight down the body. As I slide up the neck, cephalad, and slightly lateral, the interscalene view is found. Here you can see the pulsatile subclavian artery. The structure that you see here looks like a traffic light between the anterior and middle scalene muscles, which is what you're aiming for. This is the C5, C6, and C7 nerve roots. So from here, I will infiltrate the skin with 1 to 3 milliliters of lidocaine for partial pain relief. I'm inserting my needle in plane through the skin and middle scalene towards the traffic-like structure. I just felt my first pop, which means that I'm through the cervical fascia, passing through the middle scalene. I also felt the second pop, so that means that I penetrated the brachial plexus fascia sheath. This is the zone that we're aiming for, so from here I will aspirate to make sure that I'm not intravascular, and I inject 1 milliliter of local anesthetic to verify that I'm in the correct location. Now that that is confirmed, I'm going to inject 10 to 15 milliliters of local anesthetic. You would see the C5 through C7 nerve roots spreading away from the needle, and then we wait for the onset of about 15 to 20 minutes since we use 0.5% ropivacaine today and the patient is ready for surgery.